I'm going to highlight some facts about hoarding in older adults because that's one of the areas we wanted to focus on today. And we know that in nursing home residents, 15% have hoarding behaviors, and 25% of elderly people in daycare programs also have hoarding behaviors, which is quite high. We know geriatric service agencies are involved in 40% of complaints about hoarding to health departments, and 50% of hoarders are in the geriatric age range. And in psychiatry, we include anyone over 60 as geriatric. 25% of people who hoard have some kind of cognitive impairment. This may not be Alzheimer's disease or dementia, but it may be difficulties processing information or remembering, categorizing, or sorting, as Suzanne had talked about. And in dementia, the rates of hoarding are very high, up to 22.5%, and people with dementia will hoard any item, including food and garbage. We'll talk about that as well, because there's a syndrome known as Diogenes syndrome, some of you may have heard of. It's generally in the elderly, and it's also known as senile squalor syndrome, social breakdown syndrome, or syndrome of extreme self-neglect. Now, this was named after Diogenes of Sinope, which is now Turkey. Diogenes was a Greek philosopher from the 4th century BC, and he became a beggar intentionally and lived in a large tub, and you can see that in this artistic depiction on the slide. He ate in the marketplace, he used to urinate in the theater, ate scraps off the street, and he was known for shunning norms about decency and social behavior. He was exiled from his city for that reason, and because he used to go and disrupt the lectures being given by Plato and Socrates. He was quite infamous for this. Most common characteristics of Diogenes syndrome are domestic squalor, self-neglect, very serious social isolation, very isolated people, the hoarding of rubbish, or silogomania it's called, and a lack of shame. People with Diogenes generally do not have any sense that what they're doing is abnormal, and they do not seem to feel shame about it. Some other features, the annual incidence is 5 to 10 out of 10,000 for people over 60, which sounds like a small number, but statistically actually is significant. Men are equal to women in terms of prevalence here, and most of these people live alone, but there's something known as squalor à deux, which is where someone with Diogenes syndrome has a partner or a housemate who develops the syndrome alongside, or at least participates in the hoarding. This is the type of hoarding that's more prevalent in upper social classes, interestingly, and also in people who are highly educated. I once had a patient who was a physician with this disorder, very smart man, but did not recognize that this was a problem. And also Diogenes is associated with frontal lobe disease. I know we have limited time, but I cannot resist going on a little philosophical tangent here. Just to say that I've been reading about Diogenes and the philosophers in his school of Stoicism and skepticism, and actually their beliefs were not exactly consistent with people who hoard. And I think that Diogenes would not like to know that his name was attached to people with Diogenes syndrome, because his belief was we should not rely on items, we should not be materialistic, and we should live in the moment. And a lot of people who hoard are very much obsessed with certainty and security and the accumulation of things. So I'm going to move on now to talk about the assessment and treatment of hoarding. When we do hoarding assessments, we ask patients these questions, and you may find these questions useful to ask your family members or even yourself if you suffer from hoarding. We ask, are your belongings in piles along the sides of rooms? How high are those piles? This is a safety question, because especially if you're frail and elderly, something could fall off the top of a pile and injure you. We ask, are you limited to pathways in some rooms, little goat paths, or actual goat paths where you have to walk over the piles of things that you hoard and there's no path on the floor? We ask if any rooms are so cluttered that they cannot be used, especially essential rooms like the bathroom and the kitchen. So you might want to ask, do you still sleep in your bed? Is your kitchen too full to use? Can you use your bathtub? The last two questions are key as well, because they indicate the level of insight a person has into their hoarding, and people with better insight are much more likely to respond to treatment. So we ask, do you feel that clutter is a problem for you? And are you willing to work on getting rid of things? In terms of when and why to intervene, I'm going to hand this over to Dr. Duchen, and then I'll come back with a few.
So, when and why to intervene? Ideally, early intervention should take place, but given the information that we received today, where hoarding starts at a mean age of 13 and first age of intervention is 50, people have about 37 odd years to accumulate items. The reason why we intervene is the person may be suffering both psychologically and physically. We want to avoid personal crises. People who hoard, who are admitted to hospital for medical conditions, have a much higher mortality than their peers who do not hoard. There are also obvious issues such as safety. Justine mentioned items falling from piles of hoarded items. In addition, there are fire hazards, particularly if hoarding takes place in the kitchen or adjacent to electrical appliances. Elderly people may be much more vulnerable to falls, and if their living space is so cluttered that they have difficulty walking, they're at much higher risk of falling and injuring themselves. And obviously, if there's a lot of food particularly, and even if there isn't food, infestations of vermin, rats, mice, insects can certainly take place. And the other reason is to reduce social isolation. Many people who suffer from hoarding are quite isolated. They do not like people to come into their homes. They're embarrassed, they're ashamed, or even if they're not embarrassed and ashamed, they know that other people, they don't want the world to see how they actually live. And again, in terms of avoidance of public crises, the items are very similar to the individual. You want to avoid fires. I think in the last couple of years there was a fire in an apartment building which started in a hoarder's apartment, and it didn't only affect the hoarder, but the entire building had to be evacuated, and the people had to live, I think, in a hotel for a couple of months. Also infestations. If a hoarder lives in an apartment and there's an infestation of vermin, this will often spread to the neighbors, and blocked exits where people cannot escape if there's too much accumulation of items. And obviously this does become a public health issue, and oftentimes public health authorities are called into people's homes when there are concerns about hoarding.
We've alluded to some of these things already, but I'm going to just talk about what we call the red flags in hoarding. These are the danger signs, and these are what we must include in every hoarding assessment, and what we'd encourage people to speak to their relatives, friends, themselves about. First of all, First of all, it's very crucial to assess whether there's been a history of fire or whether there's a history of fire hazard, someone burning incense and not blowing that out before they leave, where there are stacks of paper everywhere. We assess for whether there's a history of falls. Has the person tripped and fallen a lot? And whether there's a risk of falls. And a falls risk assessment includes a look at the house and whether there are tripping hazards, but also whether the person has poor mobility, how frail they might be, what medications they're taking, because some medications actually increase the risk for falls, and medical conditions or visual or hearing impairment that might also increase the risk for falls. We ask about infestations and the potential for infestation, and this is especially important in Diogenes syndrome, where garbage and sometimes organic waste is being hoarded. The ability to enter and exit the home and essential rooms is important in terms of using the kitchen and hygiene, but also, as in the Collier brothers, it's important that emergency personnel can get into the house if there's a call to the ambulance, or that the police can get in, or firefighters, and so on. So this is the ability to access emergency services, which is crucial. And then last but not least is hygiene. We assess people for hygiene and what is their risk of infection. Many people who hoard do not pay close attention to their hygiene all the time, and there's a risk for pneumonia and sometimes bladder infections. So that's also important to ask about. And the principles of treatment, the most important thing, the key word is multidisciplinary treatment, and what this means is the treatment has to come from a variety of sources to be effective. These are some of the main principles listed on this slide. So we treat any underlying psychiatric or medical disorder, as we've talked about. We try to ensure the person has adequate visual and hearing. and mental capacity. And what mental capacity refers to is whether someone is able to understand and to appreciate what illness they have, what impact it may be having on their lives and their health, and what the options for treatment are and risks and benefits. Some people are also not necessarily capable with respect to the place of residence that they live in, and we do a capacity assessment for that when it's needed. We check a person's environment for safety, and if possible, we never forcibly clean a person's home because this really takes away from someone's autonomy and it can be experienced as intrusive and quite traumatic. We educate the patient and family, and I'll provide you with some of the information we give shortly. And we provide books and community resources, and then treatment comprises also psychotherapy plus or minus medication. In the elderly, there are some other principles of treatment that are important. We often involve agencies such as the Community Care Access Center, or CCAC, home nursing agencies, the fire department for a fire risk assessment, animal control if there's animal hoarding, and public health if there's infestation or disease risk. And we involve the police only if absolutely necessary to bring a person to the hospital, for example. We involve adult and child protective services if we suspect elder abuse or child abuse, and there is often elder abuse in cases like this, and a capacity assessment, as I had described before. And I cannot emphasize the word multidisciplinary too much, so I have it again on this slide. Here I'm just going to highlight the issue of family accommodation. You may be familiar with this. It's what family members do when they live with people who hoard that is meant to help the person, but in fact reinforces the hoarding behavior. So you have to talk with the family about how much they're accommodating to the person's hoarding. For example, are the family members acquiring items on behalf of the patient? Are they avoiding going into certain rooms or avoiding discarding even garbage just to keep their family member from getting distressed? It feels good in the moment and it feels like you're helping the person, but in fact this reinforces the hoarder's belief that it would be dangerous to discard things or to not acquire things. So family accommodation is a slippery slope that we always try to address. And then support from numerous resources. I've listed some, but not all of them here. There's usually a family doctor involved, psychiatrist, psychotherapist, homemaking, case management. There are geriatric outreach teams. And there's a program called Extreme Clean that actually comes in and does a radical cleaning of the home. But this has to be done with the person's permission unless it's a desperate situation. There are day treatment programs, and Meals on Wheels sometimes needs to come in if someone can't leave the home. These are just some examples.
Would have been taken over by VHA, which does the Extreme Clean?
Yeah, we will talk about it at the end. Thank you. Yeah. I'm going to ask people to save questions to the end, but we'll have half an hour then to talk about these things. I have this antelope fight here just because there is a raging debate about medication versus therapy. And I'd like to just describe that a little bit in terms of what the best treatments are for hoarding and OCD, which is quite similar. The basic principles are that we consider therapy, psychotherapy, in every case because it is the gold standard treatment. It's the most effective treatment, and it is the one that prevents relapses, whereas medication does not. The types of therapy are very different from what a lot of people know of. This is not Freudian psychoanalysis, but this is called cognitive behavioral therapy, which is a very practical approach. CBT is the other name. It works by helping a patient to understand what are the distorted beliefs and behaviors and cognitions or thoughts about their hoarding that perpetuate it, and by changing those in logical dialogue, eventually changing the fears around discarding items. Emotions themselves are quite spontaneous and can't easily be changed, but you can change thoughts and behaviors, and so that's the principle of CBT, and it's actually very effective. There's a specific type of CBT called exposure and response prevention, or ERP, and this is where, especially for OCD and hoarding, you expose a patient to his or her fears in a very stepwise, hierarchical fashion, starting at the bottom with the least feared situation and at the top with the most feared. So the first exposure, and I'll give an example shortly, but the first exposure would involve something that causes a bit of anxiety but not too much. And an example of this might be for someone who acquires a walk out into the community without acquiring anything. That might cause 40% anxiety, and you do this exposure, and then once the person has mastered that, you move up to the next item that's a little more anxiety-provoking. So again, I'll give an example of that. The response prevention part is that you inhibit the response. So when the person's response to the environment is to acquire or is to keep, you do the opposite and have the person discard or not acquire. And in general, the situations where medication really is needed are listed here when the hoarding is more severe, when there's very poor insight in the person or poor motivation to change, when there are cognitive deficits like Alzheimer's disease or dementia and the person cannot do the therapy, when there are multiple other illnesses that make it difficult, and entrenched personality factors that are not as easily amenable to a structured therapy like CBT. And unfortunately, in this society we live in our public health system, CBT is often not available, and so people have to wait a very long time. And for those people, medications are a reasonable option, at least to start. This is a very basic medication primer. I'm just going to mention the typical medications we use for hoarding are the same as for OCD. The serotonin reuptake inhibitors are the first-line treatment. You may know these as Prozac, Paxil, Zoloft, and the like. And these are the most commonly used. They're quite safe, and they have some benefit, but not full benefit, and this is where the therapy comes in. The older antidepressants are used sometimes as well. There's one that you may have heard of called clomipramine or anafranil, which is used often in OCD, and it's more effective than the newer medications, but it has a lot of side effects, and we try not to use it unless we really have to. There are some alternative strategies like antipsychotic medications or anti-seizure medications being added on to serotonin medications as well. And some other medications, more recently one called memantine, which was initially developed for dementia, but there's some reason why it seems to help with OCD. I'm going to talk about how CBT works for hoarding. I hope I don't go over time. I don't have a very clear sense. Okay, we have 10 minutes. So I'll try to go through this, and then if there are more questions about the therapy at the end, feel free to ask. The core components are to educate the patient and the family, and then to use both cognitive and behavioral strategies to address the hoarding. And there are three components that have to be addressed. There's the acquiring component, the discarding component, and the clutter or organizational component. And I'll describe each of the cognitive and behavioral strategies in an example. We also target organization and decision-making in a very concrete way, and we talk with the person about how to organize items and how to decide what to keep or what to discard. Treatment rules are that the therapist does not touch items without the patient's permission. Decisions to discard, keep, or sort are made by the patient or the client, and we establish categories before therapy starts as to what should go where. We have the only handle it once rule, which helps with indecision because a lot of people who hoard just cannot decide whether to keep something or not. So we allow people to handle an item once and make a decision, but that's it, if at all possible. We ask people to think aloud while they're sorting their possessions so that we know the cognitions and the way they're thinking about their hoarding. And the treatment proceeds up a hierarchy, as I described earlier. And the favorite rule is the in versus out rule, which starts the moment treatment starts, which is whatever comes into the house, that same amount of items has to leave the house on that same day to prevent further accumulation. So here's an example of a hoarding hierarchy. This is from a case report done in the literature that we use quite often. This is someone who has a lot of trouble with acquiring. You can see on the right there's the fear rating, which is known as SUDS, or subjective units of distress. And we have someone rate from 0%, no fear, to 100%, which would be all-out panic, how much different things scare them. For this person, the easiest thing would be going out into the community and not bringing home flyers. So that's 25%. That's definitely workable. A little higher than that, we'd have discarding old receipts from the grocery store or purchases. Discarding the person's children's old schoolwork was quite high at 90%, and discarding something recorded as audio information for some reason was the most distressing thing for this person. So you may already have some idea of where we would start if we were doing therapy with this patient. We would start at the bottom at 25% and have the person go out into the community and not bring home flyers, pass by stores, pass by newsstands, not pick anything up, and rate their anxiety level. And they would keep this behavior going until the anxiety went down by half to 12%. And this actually conditions the brain to become less fearful in future circumstances. It's a way of rewiring the brain with therapy. So after that becomes easy, we may then have them go to the doctor's office and not bring medical information home and repeat this until that becomes easy. And you'll find if you do this, the item that starts out as 100%, by the time you get to it is usually down to about a 50 or a 60. In terms of how to help people categorize or sort, there are two things we do. We categorize unwanted items and we categorize saving items to keep. In terms of unwanted items, we look at what should go in the trash, what should be recycled, what could be donated, and what is undecided, and what do we sell. Then we develop a list, a very concrete list of items to be removed, and develop an action plan. And this sounds very sophisticated, but it's really not. It's quite granular, quite concrete, that we have to say to the person, what's your action plan for removing this item? Is it that you're going to put it in your blue bin on Tuesday night, take it to the curb Wednesday morning? It has to be that specific for it to work. In terms of defining categories for saved objects, we ask people to keep similar items together. So kitchen items go in one room or one box and living room in another. We choose limited numbers of locations to avoid confusion in terms of where to put items. So maybe boxes that you're using to sort things should all be in the same room. And we help patients select their final location. Where is this item eventually going to go in the house? And here's an example of the cognitive component taken from another study by Steketee and Frost. You'll see one of their books up here. This was a patient who predicted, if I throw this item away, it will feel like death. And prediction 2 was, if I throw it away, it will feel like death forever. And this is quite catastrophic, so you can see why the person doesn't want to discard. So 1 minute after discarding an item, the person says the anxiety rating is 100%, but it does not feel like death. And 24 hours after throwing it out, the anxiety level is down to 10%, which is barely perceptible, and it really doesn't bother the person at all. So after you've had a successful exposure like this, you come back and you reappraise the thoughts. And the reappraisal is neither prediction came true. It didn't feel like death either time or forever. And so you have the person create a new hypothesis. This person said, the thought of throwing things away is worse than doing it. This is a very common hypothesis people have after doing this therapy. And if I throw something away that I'm deathly afraid of discarding, then it will not feel as bad as I think, and the bad feeling won't last as long as I think. And I'll tell you one thing I do when I'm working with people who hoard is I'll ask them to bring an item to my office and to leave it with me for the week and to come back to the next session. And I ask them at the next session to rate their anxiety. And most of the time they've forgotten that they've left the item with me, which just shows that the anxiety really does decrease significantly. Here's a lovely success story. These are some pictures of, I think I went too fast, of a patient of Dr. Richter's. This is before. And you can see the top layer of these two is also the before, and the bottom is the after. And in the end, you can see how beautiful this space becomes from something that's unrecognizable. So that's a success story. I will skip over the rules for acquiring, but we can come back to this if anyone wants to know the examples of how to treat acquiring, because we're running out of time. And just a note on treatment outcomes, it is sobering. I mean, unfortunately, a study on hoarders over 65, which had the results that most studies of this age group and with this disorder have, showed that after 26 weeks of very good individual CBT, 25% of people showed an immediate benefit, but after 6 months it did not last. And those who adhered to treatment, those who really followed the rules of treatment well, had a better prognosis and did better. I don't want this to make any of you feel hopeless for yourselves or for your loved ones, because it is quite sobering, but I will tell you from our experience leading OCD groups and hoarding groups that the people who really do stick with the treatment get much better. Sometimes as many as 80% of those people will be significantly better by the end of treatment, but they really have to be motivated and do the treatment. And just a brief note on family members. We have a handout, which I unfortunately forgot to bring today. I'm happy to send it by email to anyone who wants it, and I'll provide that to people who would like that. This is from that handout, some tips for family members. We suggest that you learn as much as you can about the disorder, hoarding or OCD or both, and that you try to view the person's symptoms as an illness, but not as a character flaw, because the latter is more blaming. That you aim to be positive and supportive, which is at times challenging, and try to maintain a normal routine in the household in terms of times to eat, times to go out, and work if there is work. We cannot emphasize enough how important it is to set limits, and I talked about this earlier, not participating in the hoarding as much as possible, because this actually makes it worse when you participate instead of better. We suggest praising and encouraging small accomplishments, because even the tiniest gain is very painful and hard to make for someone with this disorder. And to take good care of yourself as well, because as a caregiver you need to be well. And also to use humor when possible, because that sometimes really does help, especially in times of severe stress or panic attacks. And just going back to Mrs. X, I would mention for her, this is the case that Dr. Duchen brought up at the beginning. Now that we've learned about how basically to approach and treat hoarding, we would start with a safety assessment for her. And we know she's cognitively intact, so she doesn't have dementia or memory problems, and therefore she can do the cognitive behavioral therapy. And this is the first thing that we would try. We would have her discuss the emotional meaning of objects to her, and this is especially important in the wake of the loss of her husband. Objects are associated with him, and she understandably does not want to get rid of them. And the meaning of the objects as a tie to the past. Existential concerns about her own death, maybe. We would create a hierarchy and work through that in terms of discarding and acquiring, and then reassess her cognitions as per the example I gave you before. And then if this doesn't work, or she remains very unwell, or is unable to do the CBT, that's when we would add in an antidepressant medication, one of the serotonin medications I talked about before. And we have suggested readings. You can browse up front, and the list that we gave out, I think we're going to try to get more copies. There are numerous books on hoarding and OCD, and they overlap with each other. And we would like to just mention the Sunnybrook Clinic, where we do assessments and treatment for people who hoard. There's a number here for referrals. Physicians have to make those referrals. You could get your family doctor to do a referral. And we also do research on the genetics of hoarding and OCD, and we have a pool of 9,000 patients throughout the world right now, providing a very good genetic sample, and are always looking for more people who'd be willing to participate. And so I'll come back to this for anyone who needs this information, and for now we just want to say thank you for listening, and we hope to be able to answer your questions now. Sure, yeah, thank you very much.
Rules for acquisition slide.
So someone's asking if we can show the rules for acquisition slide. Yeah, we'll come back to that other one, I promise. Don't let me forget. The rules for acquiring. So basic rules are there must be an immediate use for the item. There has to be time to deal with the item that you acquire appropriately once it arrives in your house. You have to have the money to afford the item and a space in the house in which to put it. And if the person has those 4 criteria, then they are allowed to buy something in the therapy. Does that answer your question? I'll leave it on there for a moment.